So the next topic that we're going to go into for this lecture series is we're going to talk about edema. So what is edema? It's abnormal accumulation of fluid in the interstitium located beneath the skin and in the cavities of the body. Edema can be a normal response to the body to inflammation or injury, such as a twisted ankle, bee sting, or skin infection, will all result in edema to the involved area. In some cases, such as infection, this may be beneficial to allow the cells needed to fight the infection into the area where it needs to be. So in order to understand edema, you need to understand a few definitions and concepts. One of the concepts and definitions you'll need to understand is the different fluid compartments in your body. There are basically three major fluid compartments in the body. The first is extracellular fluid, and that's the fluid outside the cells. This can be broken down further into interstitial fluid, which is a fluid which bathes the cells and surrounds the cells, and that's found in the interstitial spaces or tissue spaces. And the next one is plasma, which is the fluid component of blood, and that's the fluid that transports the red blood cells, nutrients, and oxygen to where they need to go. The next compartment that you have is the intracellular fluid, or ICF. This is the fluid found inside of the cells. It's made of a complex mixture of substances dissolved in water. Next, we're going to go talk about definitions in regards to the pathophysiology of movement of these fluids between vascular structures. So the movement of fluid between vascular is controlled by opposing effects of vascular hydrostatic pressure and plasma colloid osmotic pressure. So first one is osmotic pressure. It's the hydrostatic pressure produced by a difference in the concentration between the amounts of solutes between solutions that are separated by a semi-permeable membrane. It's basically a difference in concentration, and this is more found at the venous end. Hydrostatic pressure is the pressure exerted or transmitted by fluid at rest, and this is found more at the arterial end. So Starling forces is the next thing we're going to talk about, and this is generation of interstitial fluid is regulated by the forces of the Starling equation. Hydrostatic pressure within the blood vessels tends to cause water to filter out into the tissues, and this leads to a difference in protein concentrations between blood plasma and the tissue. As a result, the oncotic pressure of the higher level protein in the plasma tends to draw back water into the blood vessels from the tissue. So the Starling equation basically states that the leakage of fluid is determined by the difference between the two forces and also by the permeability of the vessel wall to water, which determines the rate of flow for a given force imbalance. This is the Starling equation. You don't need to know all the equations, just understand the concept. It basically is used to govern the exchange of water between the capillary microcirculation and the interstitial fluid. And when the values change, the differences will cause the swelling that we see. So you don't need to know all these numbers or the equation, just understand the concept. Okay, so fluid within the tissues follow Starling hypothesis. That's why it's so important to know. An increase in intercapillary blood pressure and decrease in osmotic pressure at the arterial end causes plasma to flow from the capillary to interstitial fluid, and that's where there's an exchange in nutrients and oxygen from the blood to the interstitial fluid and transfer the toxic substances out from the cells. As the blood comes in from the arterial end, this is what's basically happening. As the blood continues along the capillary loop, there's a gradual increase in interstitial osmotic pressure and a decrease in hydrostatic interstitial pressure due to fluid or electrolyte transfers from capillaries to the interstitial spaces. This all depends on the protein levels within the capillary and the cell as well. So when the blood starts flowing down from the arterial end to the venous end, there is a decrease in capillary pressure and there's an increase in osmotic pressure at the venous end, and there will be fluid reabsorption into the capillary. Alteration of this balance causes fluid retention in the tissues until the molecular concentration can balance between osmotic effect and rise in hydrostatic interstitial pressure. So the balance can become altered, and if there's a blockage, it can change the balance in the vessels between the two forces. So the lymphatics, it's just a secondary circulation system. In a system that helps to drain the interstitial fluids and excess fluids in the cells that are not taken up by the other vasculature, the arteries, capillaries, and veins. So there are four major mechanisms that cause edema to occur in the body. The first, number one, is the increase in hydrostatic capillary pressure seen in patients with kidney failure, increase in venous pressure, or increase in sodium. Number two is when you have increased capillary Number two is when you have decrease in plasma proteins. So what happens is there's a decrease in the number of proteins in the fluid that starts to this starts to resemble the interstitial fluid. And when you have a decrease in osmotic pressure, the fluid is leaking out and not being taken into the capillaries. So number three is increased capillary blood vessel wall permeability, and that happens due to capillary damage, and you get a leakage of proteins, which can occur with inflammation or infection. And the fourth is blockage or obstruction of fluid clearance in the lymphatic system, and this can occur from infection, inflammation, surgery, or cancer. So this is just the same thing that we went over in the previous slide. It's just a simplified version. So the four main causes are increased hydrostatic pressure, capillary permeability, reduced osmotic pressure, and lymphatic obstruction. Okay. So now we're going to talk about pitting versus non-pitting edema, and these are two different types of edemas that you will see in the clinic in patients. Just two ways of presenting itself. The first is pitting edema, which is dependent edema when the fluid-filled lower extremities are compressible, and you will see an indent in the skin when it's pressed on. So basically there's more fluid in pitting edema causing the swelling as compared to non-pitting edema, which just has more protein in it. Characteristics may be asymmetric, often tender, usually chronic or recurrent, associated with hemosiderin deposition, and ulceration often occurs. Non-pitting edema is basically just a protein-rich edema due to abnormalities of lymphatic drainage. You get this material that stays in the cell, so basically it becomes non-compressible. Characteristics of non-pitting edema are it's usually non-tender and painless. Does not vary much during the day. Ulceration is rare, and you'll start to develop this hyperkeratosis or thickening of the skin. Some patients will also start to develop neuralgia or neuropathy because you get compression of the nerves. So that's why sometimes it's painless. This is the pitting edema scale. You're going to use this when you want to characterize the type of edema that you see on a patient in your notes. So basically what happens is you push on the skin and hold down for about 3 to 5 seconds. And if you can push about 2 millimeters, it's considered +1. 4 millimeters, it's considered +2. 6 millimeters, it's considered +3. And 8 millimeters, it's considered +4 pitting edema. So you always want to document that in your notes when you're evaluating a patient. So basically there's 3 types of edemas, and the categories are based on the underlying cause of the edema. 3 types are cyclic, unilateral, and bilateral. So idiopathic cyclic edema, this is basically a full body edema where the patients will get swelling in the face, hands, trunk, limbs, and it's mostly seen in young women. Sorry, I was supposed to say 20 to 30 years old, not 20 to 20. It's basically pathological fluid retention in the upright position, and women typically notice a weight gain as the day progresses. It's related to diabetes, obesity, and emotional problems such as anxiety and depression. This is a diagnosis of exclusion, so you want to exclude everything else possible that could be out, and this is just what you're left with. It's usually self-limiting, lasting from 6 months to 20 years. Treatments consist of progesterone, weight reduction, spironolactone, salt-losing diuretics, pathoglytics, bed rest, restriction of salt intake, and compression dressings. Okay, unilateral edema is the next one we'll talk about. This is basically an asymmetrical distribution of edema. So you can have both legs that are edematous, but the one that may be more than the other, this would be considered unilateral edema. So it can be bilateral, but it can just be unilateral as well. It's caused by local factors. It usually presents as an acute onset with inflammation and predisposing factors suggesting thrombophlebitis. It could be caused by sudden snap in the posterior calf, any type of trauma, gradual onset of edema with pigment changes, and varicosities suggests venous stasis disease. Okay, so some common causes of unilateral edema are chronic venous insufficiency. Then that's probably the number one cause of unilateral edema. So, and the second one is DVT, lymphedema, infection, any type of trauma, compartment syndrome. And a lot of times when you do see unilateral edema, you want to always try to rule out DVT. That's pretty serious, so you want to just always rule that out if you see a patient come in with the clinic unilateral edema, pain, tenderness, redness of the leg. Okay, so the first cause we're going to talk about is chronic venous insufficiency. And this can result from symptomatic or asymptomatic deep vein thrombosis. Basically, the valves are destroyed and the vessel walls are weakened, which creates increased venous pressure upon dependency and resulting in swelling. Early on, the edema will present as a soft pitting edema, but could become progressively fibrotic and indurated. Varicosities, pigmentary changes, and stasis dermatitis and ulcerations can develop. Patients can also develop post-phlebitic syndrome, and congenital abnormalities of the venous system may also occur. Okay, so this is venous stasis dermatitis. It's often confused for cellulite of the lower extremity. You will get inflammatory skin disease that occurs on the lower extremities in patients with chronic venous insufficiency with venous hypertension. So stasis dermatitis is usually the earliest cutaneous sequela of venous insufficiency, and it may be a precursor to more problematic conditions such as venous leg ulceration and lipodermatosclerosis. Okay, so when the skin changes start to develop with stasis dermatitis, you'll see acute inflammation with exudate and weeping patches and plaques on the leg. As the swelling progresses, we talked about this before, when the fluid leaks out of the vessels, you get hemosiderin deposits. So patients with long-standing lesions will have lichenification, and hyperpigmentation as a consequence of chronic scratching and rubbing. Okay, so the venous system is divided into the superficial and deep systems. The superficial system consists of the great saphenous vein, which drains the medial aspect of the foot, and is joined by the femoral vein just below the inguinal ligament. There are also many communications within the deep system. The medial marginal vein branches off the great saphenous vein, and it communicates with the deep posterior tibial vein. Then you have the posterior arch veins also connect with the deep posterior tibial vein. And the small saphenous vein drains the lateral aspect of the foot and the calf, and it usually drains into the popliteal vein. So the deep venous system consists of the anterior and posterior tibial veins, the peroneal veins, and they all follow the arterial system and have multiple anastomosis. So with the venous system, there's three sets of muscular veins that drain into the soleus and the gastroc muscles. They're valveless and often the site of thrombi as the blood becomes stagnant. The Virchow's triad was developed to describe the etiology of the thrombi, which we talked about in previous lectures. So this should all be kind of familiar to all of you. You have the changes in the vessel wall which results from endothelium damage, alterations of blood coagulability, and changes in blood flow, in which that's stasis. The two most important factors are the blood stasis and the activation of the coagulation system. So basically, there are three proposed theories on venous angiopathy, and the first is the fibrin cuff theory, which involves the accumulation of fluid containing fibrin into the pericapillary space. The next is growth factor trapping, which is trapping of growth factor by fibrin and other macromolecules, making them unavailable to facilitate healing. Third one is white blood cell trapping. So this is basically trapping of the white blood cells in the capillaries or post-capillary veins. Okay, so venous disease can be described by three different terms causing edema, which are inflammation of the local veins, such as phlebitis, thrombophlebitis, and phlebothrombosis. So phlebitis, thrombophlebitis, and phlebothrombosis are terms to describe the extent of venous disease, like I just said. Phlebitis represents the inflammation that occurs prior to thrombus production. You'll get localized pain and tenderness. Thrombophlebitis is inflammation, tenderness, and cord-like texture of a vein. And phlebothrombosis is the presence of a clot within a vein and is not associated with inflammation. So first, DVT we're going to talk about. This is something common that you'll see when you start your externships and residency. So basically, it's an acutely swollen, painful leg that may be erythematous and warm. It could also present subtly with mild, painless, and asymmetric edema. Pitting edema occurs rapidly. So basically, the Homan sign or any type of physical exam is often unreliable to rule out DVT. So you'll need to get further testing done. Different types of tests that we can do are the D-dimer, which signifies existence of a thrombus. So the gold standard for the D-dimer is the ELISA, and that has a 95% sensitivity rate. Doppler or plethysmography are other modalities that you can use, but the gold standard used to be venogram and now it's ultrasound. So that's the gold standard. Okay, so some predisposing factors for the development of DVT. You can go through advanced age, obesity, smoking, pregnancy. You guys can just go through the list. This is a great mnemonic that you can use for the causes of DVT. It's I am clotted. So you want to go over this. It's pretty self-explanatory, but make sure you know this, so it's very important. Okay, so superficial thrombophlebitis. These are when the superficial veins are involved instead of the deep. So you get localized edema and tenderness with a palpable indurated cord. The most common cause is varicose veins. Differential diagnosis, you want to keep in mind inflammatory lesions such as erythema nodosa, induration, nodular vasculitis, insect bites, and non-suppurative paniculitis need to be considered. Treatment consists of elevation, rest, moist heat, elastic stockings, and anti-inflammatory drugs. Okay, so lymphedema, this occurs when you have an accumulation of protein-rich fluid in the tissues that are caused by a transport failure of the lymphatic system. There are two main mechanisms of why this occurs. The first is mechanical insufficiency, which is lymphostatic. So you have low flow edema and low volume insufficiency, and it's a breakdown of the transport capacity of the lymphatic system. Now you also have dynamic insufficiency, which is lymphedynamic. You have high flow edema and high volume insufficiency. Basically, a high load is placed on the lymph system, which exceeds its capacity. Okay, so there are multiple causes of this, and it can multiple causes of the lymphedema. Primary, this is when lymphatic vessels or nodes are either absent, aplastic, underdeveloped, hypoplastic, or too large and incompetent, hyperplastic. Secondary causes are caused by surgery, biopsy, dissection, or radiation. So multiple causes of this, and it can be either congenital or acquired, which results in lymph stasis. Lymphatic vessels become incompetent, and with obstruction, intralymphatic pressures rise, causing dilation and valvular insufficiency. Again, many people often confuse lymphedema with lipedema, so they're just going through the differences. Lipedema is usually symmetric, painful, presents with hematoma, neurocephalus, no foot edema, and stemmer sign is negative. Lymphedema, it's asymmetric, painless, no hematoma formation, erysipelas is frequent, foot edema, and stemmer sign is positive. Okay, another cause is filariasis or elephantitis. True elephantitis is caused by these two different nematodes. When the bite from the carrier mosquito, the larva migrates to the lymphatic system, and you develop inflammatory and obstructive symptoms from degeneration, and this results in extreme edema to the legs. And eventually you'll start to develop the elephantitis. Okay, if a trauma could be another cause of unilateral leg edema, a history of trauma with clinical presentation of ecchymosis and palpable tenderness. It could be caused by a rupture of the medial head of the gastrocnemius muscle. A ruptured Baker's cyst must be considered in patients with rheumatoid arthritis or knee instability. A venogram should be taken when a patient presents. Like I said, always want to rule out DVT because any of these symptoms can mimic a DVT. You also want to rule out compartment syndrome because that could be caused from trauma, thrombi, or emboli. Okay, other causes of neoplasm. So tumors of the lower extremity may cause localized edema. They may be benign or malignant in nature. Lipomas, hemangiomas, sarcomas, and bone tumors are examples of edema-producing lesions. Pretibial mixed edema or thyroid dermopathy is a term used to describe localized lesions of the skin resulting from deposition of hyaluronic acid, usually as a component of thyroid disease. Usually this condition is confined to the pretibial area, but it can occur anywhere in the skin, and it's always usually associated with Graves' disease. Okay, so next we're going to go into bilateral edema. So it's basically just edema of both extremities, which usually indicates a systemic process. Onset is usually insidious with no history of a participating event. Edema begins simultaneously in both legs and advances to the same degree in each leg. Although pain is not generally complaint edema of systemic origin, it may be indicative of the underlying disease process. So if someone has pain with edema, it could be some type of arterial disease, and it should be considered. Clinical exam will really reveal a soft pitting edema in the feet, ankles, and lower legs, often extending to the knees. So bilateral edema, the causes, some of the common causes: congestive heart failure, nephrotic syndrome, acute glomerulonephritis, hepatic cirrhosis, and so on. Okay, so the first one I'll talk about is congestive heart failure, and this is an increase in venous pressure due to ventricular dysfunction, which causes increase in capillary hydrostatic pressure. This will cause a response to maintain the arterial perfusion. If the amount of fluid is greater than the ability of the lymphatic system to return the fluid to the vascular space, edema will result. Edema is a manifestation of congestive heart failure, but it does not correlate with the level of systemic venous pressure. Left ventricular failure will manifest as pulmonary edema, and right ventricular failure will manifest as peripheral edema. But with right ventricular failure and peripheral edema, you'll need a substantial gain of extracellular fluid volume before the peripheral edema is actually seen, which means they probably had their CHF for a long time, might not have known it. Patients will complain of dyspnea, dependent edema, and fatigue. Other things to look at in your clinical exam are rales, bronchi, jugular venous dissension, tachycardia, tachypnea, hepatomegaly, cardiomegaly, and ventricular gallop. Okay, so any type of kidney abnormalities can cause bilateral edema. Nephrotic syndrome and acute glomerulonephritis are two common ones that you may see that cause bilateral edema. Proteinuria and hypoalbuminemia are diagnostic of nephrotic syndrome. The most common cause of nephrotic syndrome in adults is diabetic nephropathy. So you'll see a lot of these patients come in and they have some history of diabetic nephropathy. Diabetic nephropathy is first clinically detected by the presence of microalbuminuria and later with overproteinuria, leading to nephrotic syndrome. So that's why it's important to have these patients and their lab work regularly checked during their workup. Liver disease is another cause of bilateral leg edema. It basically compresses on the veins, bringing the blood to the heart when it passes through the liver, and this is why it's caused. Alcoholism is a common cause of hepatic cirrhosis. Patients that present with a history of jaundice, abdominal swelling or numbness, or burning in the feet along with edema, it raises the probability of hepatic cirrhosis. Some signs and symptoms that you need to look out for are plantar and palmar erythema, hepatosplenomegaly, ascites, spider angiomas, and jaundice. And if any of these are present, the patient should be referred to be treated. So lipedema, we mentioned briefly. This is just excessive fat, and it's often mistaken for lymphedema, seen primarily in women. Basically, a deposition of excess fat in the subcutaneous tissue, but this does not involve the lymphatic hypertension or abnormal lymphatic vessels. It's characterized by the deposition of excessive fat in the tissues from the waist down to the ankles. It's familial, bilateral, symmetric, and painless. So lack of involvement of the feet and the absence of sternocleidomastoid may help to distinguish lipedema from edema. Okay, so again, you'll most commonly see it at the ankles, at the level of the lateral malleolus. Edema is usually not associated with lipedema. However, when pitting occurs, it's associated with other problems such as water retention. There's no satisfactory treatment available except diet, exercise. Okay, drugs. There are various medications that can cause edema, and it usually presents as a soft pitting and bilateral. Antihypertensive drugs that induce edema include nifedipine, aldomet, guanethidine, hydralazine. Non-steroidal anti-inflammatory medications such as ibuprofen, indomethacin can also cause edema as a result of their sodium retention properties. So there are various medications that can also cause edema, and it'll present as a soft pitting edema that's bilateral. So their medications are antihypertensive drugs that can induce edema, such as nifedipine, non-steroidal anti-inflammatory medications such as ibuprofen and indomethacin can also cause edema because of their sodium retention properties. One medication that you'll see commonly prescribed for diabetic neuropathy is Lyrica, which has an 8% chance of causing edema. And also certain hormone medications can cause fluid retention, including progesterone, corticosteroids, and testosterone. Okay, so also dependency. This is just normal healthy individuals who stand or sit for prolonged periods of time will develop edema because they have a limitation of limited to no muscle activity, and that causes increasing capillary blood pressure. So the fluid backs up and they start to get pooling into their legs. Treatment for this is some type of compressive dressing to bring the fluid back. So you want to use some type of elastic stocking or elevation of the limbs, or even exercising to elicit muscles to bring the fluid back up. So going through history and physical, it's really important to take a thorough history to have a better understanding of what the underlying issue is, and that's basically what you mainly want to treat. So you want to try to exclude any major organ systems as a cause. When a patient presents with edema, you want to ask them the duration of the edema. Is it acute versus chronic? Acute DVT should be strongly considered. Sorry. Do they have pain? Deep venous neurosis and reflex RSD are usually painful. Chronic venous insufficiency can cause low-grade aching, and lymphedema is usually painless. What type of drugs are they on? Calcium channel blockers, prednisone, and anti-inflammatory drugs are common causes of leg edema. You want to know if there's any history of systemic disease, heart, liver, or kidney. Does the edema improve overnight? Venous edema is more likely than lymphedema to improve overnight. Is there a history consistent with sleep apnea? Sometimes sleep apnea can cause pulmonary hypertension, which is a common cause of leg edema. So you want to ask if they have any loud snoring, daytime somnolence, or neck circumference greater than 17. You want to ask about their body weight and body mass index. Obesity is associated with sleep apnea and venous insufficiency. You also want to take note of the distribution of the edema. Unilateral leg edema usually is due to a local cause, DVT, venous insufficiency, or lymphedema. Bilateral edema can be due to a local cause or systemic disease, such as heart failure or kidney disease. Generalized edema is usually due to systemic disease, and you want to check the dorsum of the foot. If the dorsum of the foot is spare, because in lymphedema, but probably involved in lymphedema. On your physical exam, you're going to see if it's pitting versus non-pitting. Are there varicose veins present? Any cords, any tenderness present as well? Kaposi-Summer sign, which is the inability to pinch a fold of skin on the dorsum of the foot at the base of the second toe, and that's a sign of lymphedema. Do they have any type of skin changes? Sometimes they'll start to develop hyperkeratosis, papillomatosis, and brawny induration, which are characteristic of chronic lymphedema. You might also see brown hemosiderin deposits on the lower legs and ankles, which are consistent with venous insufficiency. Signs of systemic disease, any type of heart failure, liver disease may be helpful in detecting a systemic cause. Character and location of any ulcer should be noted, and severity of edema from slight to very marked. That's done on the 4-point scale, which we discussed previously. So a treatment for edema, you really want to just treat the underlying cause. And also use adjunctive therapy with it to control the edema. Treatment. So only by correcting the disruptions in Starling forces that lead to the cascade of water retention can the cycle be halted and the process reversed. So you want to combine a combination of patient education, sodium restriction, and compression. Okay. Like we talked about, you really want to treat the underlying causes. You can use any type of diuretics to help with the swelling and the excess of water, but you want to be careful with potassium. You also want to start with a slow, gradual compression therapy, especially if the patient has heart failure, because you don't want to really overload the heart. So start with a low gauge compression stocking, such as 10 to 20 millimeters of mercury, and you can work up to 40. Also remember that compression therapy is not indicated in patients with arterial disease, because you don't want to be compressing all those vessels. Physical therapy, exercise movement to help pump fluid back to the heart, careful diet with low sodium, and Uniboots are usually not indicated for severe swelling because the fluid moves up too quickly. For cardiovascular, it may cause fluid overload, so again, you want to start with gradual compression. These are the typical compression stocking grades. The first one is 20 to 30 millimeters of mercury, and that's for mild edema and varicose veins. Second one is 30 to 40 millimeters of mercury, and that's indicated for moderate edema, venous insufficiency, and varicosities. The third one is 40 to 50, and this is indicated for severe edema, severe insufficiency, and post-thrombotic edema. And greater than 60 is hardly ever used. That's very severe conditions, but again, it's not used commonly. Okay, so treatment for venous insufficiency, elevation compression stockings, intermittent pneumatic compression pumps, diuretics such as furosemide can be used for short periods in severely affected patients. Treatment for lymphedema, main treatments are exercise, elevation, compression, manual lymphatic drainage, again with the compression pumps, or surgery in severe cases. Prophylactic antibiotics may be indicated for recurrent cellulitis, which does happen often. Diuretics are usually not helpful in these cases. Treatment of lymphedema is often disappointing, and psychosocial support is important in these patients. Okay, so DBTs, low molecular weight heparin, it's anticoagulant and antithrombotic. Target INR you want is 2 to 3, and that's therapeutic. coumadin concurrent with heparin until INR established 2 days. Watch for heparin-induced thrombocytopenia. Other medications you can use are Plavix, COX-1 inhibitors, and aspirin, which are more preventative. Eliquis and Xarelto are, again, for treatment. If anticoagulation is contraindicated, an IVC filter can be placed in the veins. Okay, so venous leg ulcers. So chronic venous insufficiency is the most common cause of venous leg ulcers. These patients have venous hypertension or abnormally sustained elevation of venous pressure on walking, and this is caused by vein valve reflex and outflow problems, or it could be caused by both. So with the venous outflow issues, they'll have venous obstruction, poor function of the calf muscle pumps impairs venous system's ability to return venous blood to the heart, and ankle movement limitations contribute to calf pump failure. So risk factors for venous leg ulcers are advanced age, family history of CVI, ulcer history, parental history of ankle ulcers, high BMI, history of pulmonary embolism, history of superficial or DVT, lower extremity skeletal joint disease, depends on the number of pregnancies they've had, physical inactivity, and severe lipodermatosclerosis. So venous leg ulcers, venous stasis presents as pain in the legs, swelling that subsides with elevation of varicose veins. Venous ulcers often occur over bony prominences, particularly the medial malleolus. The recurrence of an ulcer in the same area is highly suggestive of a venous ulcer. It's associated with age, younger with severe CVI, don't ulcerate due to mobility, so you want to maintain the function of the calf muscle pump. Treatment is based on avoiding sustained venous hypertension. So the goal of the treatment is basically just to reduce the edema and heal the wound to prevent reoccurrence. You want to identify the underlying cause. 80 to 85% are associated with venous hypertension. So effective treatments used are elevation. Compression is a big thing that we do, and that really helps to reduce the swelling and treat the ulcers. Mobility, you want to keep them mobile, decrease obesity, improve nutrition, and skin grafts and surgery as needed. Again, the same thing, dressings, elevation, which decreases edema, enhances flow into the microcirculation, back therapy, medications, doxycycline and aspirin have been shown to be an effective treatment for venous ulcers when added to compression therapy. Surgically, if needed, debridement with grafting and procedure to address the chronic venous insufficiency. So again, compression therapy, like I said, it's the gold standard, and that's really what's going to help close that ulcer. Venous ulcers heal more quickly with compression therapy than without. Compression therapy goal is you want to reduce the edema, improve venous reflux, and enhance healing of the ulcers and reduce pain. Success rate ranges from 30 to 60% at 24 weeks. 40 millimeters of mercury is the most effective level of compression. After an ulcer has healed, lifelong maintenance of compression therapy may reduce the risk of reoccurrence. You'll see with a lot of these patients that come in with these venous ulcerations, they'll have them for years and years and years. So they really become your patient for life. And if you do manage to heal the wound, you really want to make sure that they maintain the compressive therapy. That's really important because they do reoccur frequently. Contraindications to compression therapy include clinically significant arterial disease and uncompensated heart failure, as we mentioned. Types of compression therapy: inelastic, elastic, and intermittent pneumatic compression. So in summary, you want to understand the concepts between bilateral versus unilateral edema, systemic versus localized. Treatment for both is related to treating the underlying disease. If a systemic disease is considered unlikely, the most common cause of bilateral edema are idiopathic in young women and chronic venous insufficiency in older patients. In patients with chronic bilateral edema, think systemic etiology. If a patient presents with sudden onset of leg swelling, a deep venous thrombosis should be ruled out using a Doppler examination.